Up until the year 2000, the history of venous treatment, treating patients with vein disease, varicose veins, swollen legs, venous ulcers, was stripping. Stripping was a procedure that some of you may be familiar with. It's kind of barbaric, performed in the hospital under general anesthesia, through incisions, lots of bleeding, lots of bruising, and a long recovery. Often patients were in the hospital for 5 days or so. There was about a 10% risk of deep vein thrombosis. So until this technology of endovenous ablation, or sealing of the veins from within, was developed and introduced in 2000, there really wasn't anything for me to offer patients with venous disease. We would manage varicose veins expectantly, waiting for a complication. We would manage swollen legs conservatively. I'm sorry, it could be worse. Here's some compression stockings and some instructions. Patients with nighttime leg cramps were often, given quinine. Ulcers were treated routinely with repeated applications of Uniboots, wraps, once a week for months and months on end. So when the technology of endovenous ablation was introduced, initially it was met with skepticism by surgeons like me. I thought, really? Where's the patient population we're going to apply this procedure to? Where are they? We weren't treating any patients with vein disease. And so I thought that there wasn't a very big population that needed this treatment. Well, it wasn't until I looked into it a little bit, and within about a year, I adopted it in my practice, in our practice, I should say, and the patients just seemed to come out of the woodwork. Ulcers that we were treating with boots, wraps, and everything else, not making much progress, we investigated them with ultrasound. We found the problems. We found the leaking veins. We were able to seal the leaking veins, and we literally watched these ulcers close up almost in front of our eyes within weeks, as opposed to continuing to fester for months and months on end. So my approach was, well, what do we have to lose? Let's take this patient with an ulcer, this one with a recurrent bleed, this one with impending ulcer or bleed, and let's scan them with ultrasound, find the problem, and if it's appropriate, let's seal that vein rather than ignoring it. Here's an example of a patient of mine who was told for 30 years to leave these varicose veins alone. This is a cluster of varicose veins that, until he took the trip to New Jersey and started driving back from New Jersey, were soft and compressible, and they weren't tender, and they weren't red. But somewhere along in Maryland, a small thrombus occurred. A clot formed in a varicose vein in the calf, and by the time he made it back to Fort Myers to see me, the whole thing was hot and red and thrombosed, and the clot had actually progressed into the deeper veins, and he had what we call a DVT, deep vein thrombosis, which is a bit more of a complication than you really need to have to seek attention for your veins. So he was treated with blood thinner for 6 months. He had resolution of that hot red area, and eventually we studied him and found the vein that was leaking, causing it, and were able to fix it. There's about a 20% incidence of deep vein thrombosis if you have a superficial vein that's clotted in your leg, 20%. Yet a third of physicians won't even get an ultrasound if they see a patient like that with superficial venous thrombosis. Poor circulation is what a lot of people have been told they have. Well, what does that mean? I don't know what it means. It's either the arteries are poor, or the veins are poor, or the lymphatics aren't working. Well, arteries bring blood from the heart to places with oxygenated blood under pressure. Veins bring blood back from places like the tissues, the kidneys, the legs, and the brain to the heart under low pressure to get more oxygen. So and lymphatics basically are scavengers. Whatever leaks out between the arteries and veins are scavenged by the lymphatics and returned to the circulation at the left collarbone, at the jugular vein. They come into play in patients with edema in the legs when they go to bed at night. The fluid is brought back to circulation by the lymphatic channels. The blood flow from the ankle to the groin and the veins has to go against gravity without a good pump. The best thing we have is our muscle pump. So when you're walking, when you're exercising, like on a treadmill, you're squeezing your muscles one at a time. The valves inside the veins, the deep ones in the muscles and the superficial ones, are opening and closing. As you squeeze, they open to let the blood go up, and then they're supposed to close. So they're like check valves. And there's a series of them. There's not just one. There's one, two, maybe a half a dozen in each vein. When they work fine and you're walking, blood will return to the pelvis without any problems. Once the blood gets back in the pelvis, you just have to breathe in and out, and the blood will return when you breathe in and stop when you breathe out. So from here to here, it's breathing. From the ankle to the groin, it's squeezing, and valves opening and closing. And this is the talk I give to every new patient I see in the office. I mean, you have to go through this because you need to understand how blood returns. So when the valves fail, it's because they've become weak. Instead of closing, they prolapse or reflux or become leaky or insufficient. Thus the term venous insufficiency, which leads to varicose veins, swollen legs, discolored skin, non-healing wounds, itchy legs, nighttime leg cramps, restless leg syndrome, getting up to use the bathroom 3 or 4 times a night, a lot of different symptoms. So varicose veins are a sign of things to come. These are patients I saw last week. A gentleman with varicose veins in the calf here, right here, and some early pigmentation of the calf. Ultrasound documented that he had severe saphenous vein insufficiency. He has discomfort. He has discoloration. He has varicose veins. He has venous insufficiency. Great candidate for an endovenous ablation. Here's a patient who came in to me because she'd hemorrhaged. It was impressive. I mean, I wasn't there, but 911, cleaning lady to clean the rug outside the bathroom, the whole deal. And she had both legs treated eventually with the endovenous ablation, the closure procedure. And then I saw her back last week to inject the leftover spider veins and other veins that had bled to get them to close up. These are real people. Another patient I saw, stasis dermatitis. Dermatitis, skin inflammation. Stasis, pooling. Venous insufficiency caused stasis dermatitis. It's a skin disorder, but it's a skin manifestation of a venous problem. So you can put steroid cream on it if you want, but until you fix the pressure problem in the veins, it's, you're fighting a losing battle. Our evaluation is very simple. It's a consult, a lot of education, reviewing your history and risk factors, doing a physical examination, which in my practice is fairly focused, veins and arteries. And if you have one other thing, I might look at that too, but I'll look at your feet, I'll look at your knees, I'll watch you walk to the door, but I'm really focused below the waist. Most of our patients need an ultrasound to determine the problem, where it is. Just a very small percentage of patients will come in with spider veins that they want taken care of, or hand veins they want injected because they don't like the look of them. They don't need an ultrasound. But the other patients who have veins below the knee, have symptoms on that list that you have in your trifolder, or signs of disease, they need an ultrasound to determine the site, the vein that's leaking. History, just speaking to the patient, will help me with a story, or the story will help me determine which it is. PAD is peripheral artery disease. Plaque buildup inside your arteries causes strokes, causes claudication or problems walking. So specifically in the legs, if you have PAD, this is your history. I'm fine until I walk. But when I walk from here to that library, I got to stop. And I do it Monday, Tuesday, Wednesday, Thursday, every day of the week. It's the same distance. As soon as I stop, the pain goes away. Calf and or thigh or buttock, depending on the level of the blockage. But it's reproducible. It doesn't vary from when it's raining or not, or when it's a Monday or Tuesday, or it's when you walk that distance. PAD causes pain that's relieved with stopping. Venous disease, venous insufficiency, is the complete opposite. I hate standing still. When I'm sitting at a theater or when I'm in the car, my legs are killing me. I got to get out to walk around. Thanksgiving is a terrible day for me, standing at that thing, making that turkey and all that stuff. My legs are killing me at the end of the day. I want my kids to go home. That's venous insufficiency. But if I walk around, I'm relieved. If I elevate, I'm relieved. It's better by the morning. It's worse as the day goes on. And arthritis and neuropathy, they sound different too. And the reason, I think these two slides are important because, as you'll see, I have a vein screening I do online for patients. They just have to answer these questions. And just by answering a series of questions, I can determine the likelihood that you have venous disease or not, and then direct patients in the right direction. Warning. Next slide is terrible. 50-year-old woman, about 8-10 months ago I saw in the office, developed an ulcer in her leg, was treated by a dermatologist and a wound care center in this metropolitan area with scraping with a 10-blade knife every week. You know what a 10-blade knife is? It's a surgical knife that you just basically has like a nice rounded end on it. You sort of scrape the dead stuff away. It's painful to do this. Didn't have insurance. Went through this for 4 or 5 months. I don't know. She got insurance. A friend of hers had seen me at work, came to see us. JT, my technologist, did an ultrasound to determine where the problem was. This is her ultrasound. Pardon me, I'm going to go through that slide. This is her ultrasound. And what you see here, if I can orient you, this is the groin area up here. This is the foot down here. This is the vein called the great saphenous vein. This is the deep vein system. This is where this one joins that one at the crease. That's all supposed to be blue, which means the blood is going that way, back towards the heart. All of hers is red, going back that way towards the foot. So that vein was leaking from here all the way down to the base of that ulcer. Oof. A week after we closed the vein, we do an ultrasound on every patient to make sure there's not a clot. And what you see in this is blue. It means that blood is going the right way in the deep system, and there's no color in the great saphenous vein, which means the vein is closed off. It's no longer leaking. It's no longer open either. It's closed, it's scarred, it's cooked, it's shriveled up. And then again before, and 8 weeks post. 8 weeks, not 6 months, not 2 years, no more debridement. I did not take a 10-blade to her. We gave her a prescription for $20 Silvadene, some gauze, and a pair of hose to wear. And she took care of this herself. And this changes people's lives. Imagine taking care of that wound a couple times a day for 6 months, for 8 months, for 2 years. Atypical wound. This patient had a spider bite that wouldn't heal. That's not a typical venous ulcer, but it wouldn't heal because his leg was swollen, because his saphenous vein was insufficient, as documented on ultrasound. Fixed that, got the wound to heal. Again, setting the conditions back to what they're supposed to be. The venous pressure back to 10 millimeters of mercury, not 100. So again, my call to you is to consider venous insufficiency as an umbrella of a diagnosis, an overarching diagnosis, under which different types of signs and symptoms present. This is my Jimmy Swaggart slide. 2,000 years we're in the dark. Sounds like Jimmy Carter or Bill Clinton, but it's not. Hose, injections, or stripping, and few, it's all we had, but few were good candidates for stripping. Only ulcers or recurrent bleeding. You were too old, too sick, not bad enough to strip, too overweight, poor wound healing. We operated based on best guesses. We didn't do ultrasound. We thought, well, it's probably that one. Let's do this and see how that works. Now with ultrasound, we know what the problem is. We know where the problem. We can predict the outcome. We know who to leave alone and who to treat, which vein to leave alone and which vein to treat. And this is a brief list of our goals. Achieve healing of ulcers and reduce the recurrence, increase activity, decrease the chances of blood-borne infections. An open wound in any part of your body is a problem. It's a portal of entry, an opportunity for bacteria to get into your bloodstream and attach to a prosthetic knee or hip or heart valve or arthritic knee, for that matter. And then all these other goals you see as well. So the indications for treatment are significant superficial insufficiency by ultrasound and some of this stuff. You have to have a good enough indication to hang that complication on. And that's our mantra in surgery, as a resident, as an attending, and as a vein specialist. You need to have something you're going to improve to justify even that 0.5% risk of a blood clot.